because 8 years later, she still has this movement disorder, and when her drugs were adjusted, she's got it back again.
Turn around again.
It's like agony. It's just like you're shaking all the time. You can't sit down. Then they gave me the shots for my neck and it made it worse. I kept turning more and more. And it's just like, let's say you're walking on hot sand on the beach and you couldn't get to the cool sand. And you're like that for about 20 minutes. By the time you get to the cool sand, you're relieved. Finally, I can breathe. And that's about what it is to get relief from tardive dyskinesia. Because you shake and you can't sit down. It's just complete discomfort.
So what do I do if I see mild tardive dyskinesia on a patient who's on maintenance antipsychotics? The first thing I do is not panic. Some of the biggest disasters I've seen in my practice or as a consultant is mild TD, the patient panics, the doctor panics, the patient goes off medicine, there's a relapse, there's a suicide or whatever. So the first thing I want to reassure the patient and myself is don't panic.
Have you noticed any movements of your mouth, your tongue, your eyes, your hands that bother you?
TD tends to be very slowly progressive, if at all. I tend to take some months in reconfirming the diagnosis.
As far as my mouth movements, I tried to look in the mirror the other day to see if I could see, what you saw. But I have to really stand in the mirror and look real good too.
And how about teeth or dentures?
And it's very important to do it calmly, especially for patients who've been on antipsychotics for a long time. I don't mean patients who have rapidly progressive tardive dyskinesia with only a few months of antipsychotic exposure, but the kind of patient who gets mild TD over a long period of time. Don't panic, take your time.
Now I want to take your right hand and touch each finger with your thumb.
And then in my chart, I'll usually document the aims. If I have 2 or 3 aims showing mild dyskinesia, I will then sit down with the patient and the family and make that discussion with a presumed diagnosis of tardive dyskinesia at that point.
Slight movements of your mouth. All right, and it's very mild. So the main thing, as we talked about, we're going to do right now, because you've been doing so well psychiatrically, okay, is to just have you stay on the medicine, and we're going to follow those movements. All right, we're going to monitor them every 3 months for now, which is a little more frequent than I usually do, but that's because I'm noticing them, okay?
We found that once you develop tardive dyskinesia, it doesn't mean it's going to get worse. It doesn't mean it's going to evolve into some really excruciatingly terrible syndrome, but it may. So you have to worry about each one of these patients, that when you see this, that in 2 years they're going to be like this or something really bad. But most patients, that doesn't happen. And if you talk, when I've talked to psychiatrists, and I show them videotapes of people like Yosef or people who have other bizarre syndromes, they'll say, I've never seen that. And it's true, they may have treated 500 or 1,000 schizophrenics and they've never seen it. I'm the movement disorder person who sees, the bad ones from the whole catchment area, the whole state, and I see it. And if I show videotapes of some of these patients to other people who are movement disorder people, they won't even take, without a history, they'll say, oh, that's neuroleptic induced. There's virtually no differential. They don't think this is Huntington's disease. They don't think this is stroke. They say, this is from a neuroleptic. I mean, they're very easy to identify. How do you identify those patients early on at the beginning so you know to get them off their bad drug on another drug that's presumably not going to cause it? Nobody knows.